Colonel Rush is Chief of Surgery and Director of Surgical Education at the Anderson Simulation Center and Madigan Army Medical Center in Tacoma. And we are happy to have him here.
We're going to start with I was asked to give a talk on how we can take our lessons learned in simulation and maybe apply them to civilian practice as well as vice versa, like Matt did for his laparoscopy and trauma. I'm also going to talk about telemedicine and how SAGES and the the Army or the military go back and forth with their contributions to each other. So the first part of this is going to concentrate on simulation training, and the second on teleconsultation for the military surgeon. And it's somewhat of a glossed over talk, but I'll go into just a slight bit of detail on that one. I have no disclosures, except I know this guy, who's Colonel Lim, who couldn't be here. And here we are. How does this thing work? This one? Okay, got it. So we're... No, it doesn't work.
No, you had it. You had it.
Where is it?
You had it upside down first. There you go.
Oh, there. Okay, got it. So we did a battle handoff in Kandahar about a month ago, and I am grateful to be here in the place of him, if it's possible to do that. He has done so much for us, and we all are in the military working group as well as the Society for Military Surgeons, indebted to him for his contributions. So, over the course of my career, I initially was somewhat a little high-strung. Maybe I still am, I don't know, young. And maybe a little aggressive, and maybe a little not knowing exactly where I fit into this whole military thing, despite me being a West Point graduate. But nonetheless, you try really hard. However, over the years, I've turned into more of a listener. And it's an interesting skill, one that my wife says I'm still not very good at. And listening for the point of listening versus listening to understand is a massive paradigm shift, because it's here. And so in doing this talk, you really have to listen to the voices of those surgeons who have been through this. This transition is what I'm going to call it, and we'll get to that in a second. But I'm often, being the chief for about 6 years, and I know that's not a very long time for as chiefs of surgery go, but I've had to listen to a lot of people and their problems. And at first I was really felt guttural about trying to fix problems, and that's no longer the case. And so now I usually don't do that, but I'm there to help. Additionally, I tell them that their next opportunity is just one problem away, and what are they worried about? They should be interested in having these problems come up, because that's where they're going to grow. And they have to start with themselves. And I always preface that with, when I fix these things, I always start with myself. Because to just go and say to them, although you're being direct to them, fix yourself first, well, that doesn't go very well all the time. So when you deploy, there's a good chance, especially with the war supposedly winding down, even though it's not going to wind down. It'll get to a steady level for many years, my impression. You may not be doing a lot of cases like Matt Ritter was able to do in Bagram and Balad. there just aren't that's not that kind of volume because there's less troops at risk, but yet we've got to cover an area still the size of Afghanistan, the size of Iraq. And while there are a few less surgeons there, there's a lot less cases. And so you have to be prepared for that. And it's something that younger surgeons, fresh out of residency, may not be, not all of them will be able to do that. I shouldn't say that. They will be able to do it. It's just that, hey, we got to make this better for them. Absolutely. And the way you do that is you maintain proactivity. Good and done. So, these are some of the things that you'll run into when you're doing nothing. My famous, I've shown this at a few talks, but am I still upside down? Oh, here we go. Sitting on our hands. That's a in between, taking casualties, working out. Although this is a very developed theater, this is Kandahar right now, making gingerbread houses for Christmas and just lounging in the sun. All fantastic things. But why are we here? And I always like to start this even though we know why we're here, but I like alignment. And I like us not to forget. And so when things start happening, we got to be ready. And as Dr. Martin has pointed out or eloquently put in his frontline surgery book, chance favors the prepared. And so when we talk about simulation here, we have to think about all aspects. And we're by no means exceptional at it, but this is a problem, which then offers opportunity. And so when we're seeing ourselves having this many days, and this is in the beginning of the war in Afghanistan, this many days with no cases, and then all of a sudden you get this, which is this is where the prior pictures came from, this 12-day here. You got to be ready. And how do you do that? So this is the cycle of a military surgeon. It repeats basically every 1 to 3 years about that, from what I'm hearing. I had 2 on here, but then I know that some of you out there may be doing it a little more often. And so we go from working hard at home, trying to make up potential, trying to just do our job. We'll start there. Then you got to do some sort of a train-up. In the beginning, they were long train-ups, month-long, maybe longer. And sometimes they were not exactly right before you left. And sometimes you got to keep up those trauma skills, so you got to go do this anyway. But to streamline that process and make it worthwhile is what we got to do. And so we've had a fair success at that. So we're going to give that first one a green star for now, even though a lot of you have a complaint about that. So individual trauma training is getting better. Let's put it that way. So 2, now we're talking about team training, and we also do that both when we're about to deploy, unless we're an individual augmentee, or once we get into theater, and that's why I put it on this axis here, going up to the deployed variable clinical experience. And of course, while we're in that deployed variable clinical experience, maintenance of skills, both trauma skills for when we're not busy and have these long periods of no casualties. For example, when Dr. Lim and I handed off, I'd gotten there in October, no cases and no patients for the entire time up until February 23rd. And then all of a sudden, on one of our missions, and we were going over all of Afghanistan, extending medevac rings because we were pulling in all of our resources, but yet we had to cover all the troops in risk. And so our special operators are going out there, as well as others, are going out there and doing training and assist missions with the Afghan army, and we have to cover those train and assist missions, even though they aren't necessarily engaged in the fight. They're a little ways back, maybe. And we still have to cover them, and there's a lot less of them. So most of the time we went out there, over the 20 to 30 missions that we did to go cover those. 1 day where we have casualties. That's great. A lot less of us getting hurt. But we had to be ready to go there. And there's certain things that we did. We did a lot of work on the vehicles, a lot of work on packing, because we were always asked to, oh, can you do a smaller footprint of all that OR equipment? Okay. And so we continue to do that, or try. And so we need to practice our skills downrange, and then what are we going to do about maintaining our skills that we need for back home, especially us specialists, laparoscopists, MIS like me, oncologists, maternal fetal medicine doctors. I mean, there's a whole gamut. And so individual refresher training, and of course, integrating back with your home-based team. So Ed Viester's talked yesterday about why he was so good at what he did, because he did it through constant practice. I had a discussion with some of the aviators, and any of you who are also aviators or had these discussions with them, they have to retrain after, I think it's 30 days or 60 days without having done anything, with a test pilot going up with them. And so they often plan their mission so that that never happens. And of course, you don't want to get anywhere near that limit. And so they're very good at it. Now, what does it mean in this context to be saving lives through constant practice? Well, most surgeons deploy within their first 2 years, and so there's all that cycle gaps that are cause that, and then they deploy again. And then how are we going to keep up this constant practice? Well, we can do it through simulation, or we can do some other proactive thing like doing humanitarian missions, integrating with an Afghan hospital as long as the security is okay, and maybe some training assist missions with host nation medical people. And then, of course, constant practice of trauma at home. But is there actual evidence of skill degradation out there? I've had a lot of talks about this or discussions about it, and we'll see what happens. But with the way this is going to go, some people want, well, do you do assessments? What are your outcomes? Well, we haven't looked at that in particular yet in a specified study until now. So there are civilian versus military, and some of this crosses over. Re-entry into practice, if there's a prolonged illness or someone has exited the surgical workforce, that's considered you've exited and you're not doing your job as a surgeon. Now, most states define that, if they define it at all, as anywhere from 6 months, which is very rare. Most of them are 1 to 3 years, 1 to 5 years. It's a very big range of what they define as, hey, who has to go through re-entry training. Some of them need to do it because they're administrators at hospitals and they want to get back into their practice. Some of them do it because of punitive action and they want to get their license back. Some of them do it because in the military, a command. If you take command and become that administrator, just like in the civilian leadership of hospitals, then you have to retrain. In the military, you do this transition thing that I showed you on the cycle. And you deploy, do combat casualty care, redeploy, subspecialty practice, and while you're deployed, we are employed to do our jobs. We're credentialed to do those jobs regardless of how many cases we're doing or not. That's a difference. And of course, but our case mix and case numbers might be at issue because now we have to put on all of our recredentialing, or many hospitals ask for your numbers. So that's an issue. So we did a needs assessment survey, 2 of them, and that's 2008 and 2011. To ask these questions on comfort and how surgeons felt. This is self-reported data, and there was a decreased trend in comfort level for technical and cognitive skills the longer the deployments, and that makes some sense. And that was all comers, regardless of how far out they were from residency. And the longer the deployment, there was a longer amount of time for reestablishment of skill level. At least that's what they felt. The second survey attempted to stratify more clearly which specific procedures they felt any discomfort with. And really, only the open or solid organ showed a decrease in comfort level from pre to post, and it seemed like all of the procedures trended towards a less comfort. Now, for technical skills, there's a degradation or retention in some of the resident studies that have been done after they've rotated off of a service that's high, that does a lot of cases, and then they go off to do ICU or non-surgical rotations for a while, and depending on the specialty. But what about seasoned surgeons, or at least those who have graduated from residency? There hasn't been a lot done on that. And so we developed through this Army Central Simulation Committee, which is a multi-center group that coordinates centrally all of the education centers in our hospitals. And what we did is that we formed this SANDL study, IRB approved. It's a simulation and deployment laparoscopic skills study. And it was a prospective observational cohort study where we used all the sites and tried to get as many surgeons involved in this as possible, who were going to be deployed and then return, of course. We identified 121 of them. 86 declined because this is an IRB. Can't tell them they got to do it. Study, and the ones who completed the pre-deployment survey were 35, and completed the skills assessment was 29, and then the post-deployment survey 23, and see you're going down further and further like most studies. And some of them did laparoscopic surgery while they were deployed, like Matt would, and so they were excluded. And then those who returned and immediately went back to the OR, which some people do, and did cases before they were assessed, we had to exclude them. So we got down to 15 OBGYNs / general surgeons out of the 121 identified. It's a tough thing to do. And so what are the procedures on the lap VR? We chose the lap VR. It's a validated virtual simulator. And the thing about the lap VR is that it's easy to reproduce the results without having to have everybody go through an FLS test center, for example. Some people say, why don't you just do FLS? Well, we could have done that, but we felt that to standardize it more, this would be the best way to do it. Plus, a lot of our centers already had the lap VR, and it was the cost was less. But we did get a lot of money for this. So these are some of the procedures. And if you notice here that the number there is the number of surgeons who actually did it. And you see at the bottom there, we actually put 3 OBGYNs through it and 12 general surgeons, and there was no performance differences detected. This is just some of the lap chole data on this, and I really didn't highlight any of this because there are no differences, and their trends were actually, except for blood loss, all the trends were positive. Now, you could say that that's because they'd had an initial experience with this, but it was 3 to 8 months before, 3 to 6 months before that. So yeah, they had an initial one, but they went away for a while and then came back. Now, remember, before that they actually went through the test, they actually had a period of familiarization with this. As far as cognitive and technical skills, we attempted to assess this through the survey data. It wasn't easy to do. There was a perceived decline in our third survey, and that was right before they did the simulator for prior to going out and then coming back on those surgeons with less than 10 years out from their residency. And those surgeons, we think, have possibly a decrease in confidence level because of a changing work environment and not used to that, and just general less experience than the more experienced than the ones who have been in longer. But their performance was not different. So what can we do with this? Well, you come back from deployments and you meet with your chief. You got to do that. You also go on what's called a focused provider performance evaluation plan through your credentials. It's not a negative thing, but you do this through an assessment. And this is not an assessment that is done in any at this point, any tested way or any formal way. It's an evaluation by your service chief. Unless you're the service chief, then it's department chief, and then if you're the department chief, then it's one of your other expert surgeons. And so what else can be done? You scrub in on your partner's cases. You do a good case selection. You can go to a SAGES and American College of Surgeons like I'm doing now, having just gotten back, having returned to work. I'm coming here and stimulating cognitively. If I had time to do the hands-on courses, I would. In the past, I've gone to Lee Swanstrom's course down at the Oregon Clinic, his review course, which is both hands-on and cognitive and some OR. And of course, we can do direct versus telementoring or do a fellowship. So about this cycle, where can we best help out with it? And this is one way. Here we are. This is the TC3 simulator, and it's called the Frank. It's a joint DoD and civilian University of Minnesota adventure. And what we did here was match this up against live tissue model, and we felt that while I can't discuss all the results here because they're not releasable, their simulators are getting close. They're getting closer. And with this, you can see here that the medic is trying to pack the groin for proximal junctional hemorrhage, and his assistant is trying to do the tourniquet, but he's in charge, and so he's constantly looking at that thing as well. And you notice there's a live human in there who's actually built into the floor, and they're wearing a cut suit. So what are we going to do about while we're deployed? We are going to try to take all these supplies that we have that are expired, use them for a simulator. This is a box simulator, our first version. There's the anesthesia, pumping the blood in, but it's going out into this belly thing. And there they are opening up the box and packing. And there's a Penrose down there, and if you look at that, there's a shunt placed in between this Penrose, which was completely transected by a gunshot wound. And those IV bags are there to simulate bowel. And they're all expired, of course. And this was our next version, which we did, a little upgrade with this thing that we found laying around, this torso simulator. And a similar result. So this one, I think this one was a complete transection, and they just tied it off. And then one of our OR techs got really fancy, and you always love when your people outdo you or try to outdo you. And he put together this out of some casting material that expired, this awesome simulator, filled up some condoms with some water, hooked them together like bowel, made this thing, put this expired Gore-Tex graft, tube graft in here. Here's the proximal, distal, and he perfused it just like we did with the Penrose, only with high volume tubing. And this is what it looked like at the end. We can cut into this thing, which we did, packed it, and tried to get control over this thing. And it was a stimulating event. This was actually my case, and I couldn't get that bleeding to stop at first, despite doing what I always usually do, is put a sponge at the top and at the bottom. And of course, because he had all the limbs perfused to this thing, I didn't get the crossover at the, because this was an iliac, I didn't get the right iliac done, and so it kept bleeding. So what are some of the other things we can do? This here is a simulator that Strategic Operations has made down in San Diego. They work with the Navy, and they do hyper-realistic training, which is not virtual. It's all hands-on and team training. And this is actually one of the cases we had in our last mission in Afghanistan. Very similar. You're going after the inferior pulmonary ligament here, as well as here, to try to stop this bleeding. This is an abdominal portion for this simulator, and it's excellent to also simulate open surgery. So what are some post-deployment refresher training options? No data at this point on how to best affect that confidence level, other than getting back with it, but we don't have outcomes data yet. And so that's one of the biggest criticisms of our study. We don't have outcomes, and we don't have intraoperative assessments of the surgeons, both right when they get back as well as once they have gotten some experience. Although there are some SAGES options here, of course, FLS, FES, and FUSE, which are exceptional courses which you can retake. hands-on courses, and of course telemedicine options. Telemedicine, I'll go over briefly because I'm out of time and I want Dr. Schwetzberg to have some time here. But telemedicine is a delivery of health care remotely or at a distance. This is the World Health Organization, and here we see the most common forms, some of the most common forms, and that is, although the phone is probably the most common form as well as the camera phones now, and this is the teleradiology and telepathology. So telemedicine involves providing a service over distance. It's, in most states and facilities, it requires extra credentialing. As far as telecommunications, it's a telelink, so it's technology heavy, and it also, a lot of it's not necessarily real time. Real time is harder. As far as teleconferencing goes, this is another way that the Army has used this, as well as in conjunction with SAGES in some aspects. Remember a few years ago when there was a conferenced-in laparoscopic cholecystectomy done in Bagram, the first one done in Afghanistan is what I believe. One of the surgeons who was a member here and now civilian practice, also in the Army, did a lap chole there and broadcasted it live here. Exceptional work. And this requires a telelink as well as a satellite, and sometimes it's slow, although these times if you're over in Bagram and or in Afghanistan and you're on FaceTime, it is immediate under most conditions. The DCO, or the Direct Connect Online, has a chat capability, which you're able to chat online as well, just like we're doing here. And as far as teleconsultation goes, in 04, we were doing teleconsults out of theater immediately. All the specialties were involved. Now, there's a time delay there because you put in your consult and then you waited 24 to 48 hours for the results. Most got back within 24 hours, and the consultants were both in and out of theater. Phone calls and emails were probably still the most useful. Now, the SAGES Project 6, this is Ninh Nguyen and Chris Schlotka's. They've been working on this project for quite some time, and I believe the next president, Brian Duncan, is really going to take this on. And this Project 6 means I got your 6, which is, in the airplane terminology, it's your back, the 6 o'clock position. And so what this is different. This is telementoring to try to, and their big vision is to try to continue to infuse laparoscopy successfully and safely into the civilian community practice. And what I would, and I think that they would also like to see, is that this would be also a great way to affect some of our surgeons. I'm at a medical center. I have plenty of partners to help me. But what about the practices that just have 2 surgeons? One's coming, one's going. What do? So this is a way that we can telementor. Of course, it takes both, it occurs within an educational framework, and it's done with a competent mentee. That's important, that they already know what they're doing and they can convert to open or some other thing that they're comfortable with, instead of doing what's being telementored to them. Mentoring over a distance, this telesimulation is mentoring simulators over distance. We've done this with the RP7, and it's kind of nice because you can do picture-in-picture, and you can do it simultaneously from where, like from my office, I can mentor them at the Sim Center while the residents are going through theirs, and they can see what I'm doing, and I can see what they're doing. Other platforms involve the Da Vinci Link, and Chris Locht is very good at this. In fact, he does telerobotic surgery, and actually does the surgery. Different than mentoring. He's actually the one responsible for the patient. So that's something that we'll have to deal with soon, and thank you for listening. I'm sorry I went over, but you said 30 minutes at first, so I went with it. Good. Thank you.